Welcome to the deep dive. Today we're cutting through the noise, really getting into the essential insights that underpin effective, safe patient care.
Exactly.
Our mission is to pull out the most important nuggets of knowledge from, from materials like adult health exam reviews. We're going to explore the critical thinking, the real precision involved in keeping people healthy. And I promise you, whether you're deep in the healthcare field or just, curious about how it all works, you'll find some fascinating stuff today.
That's right. And while these insights might come from exam prep materials, they really are foundational principles, critical thinking skills that are just invaluable out there in real-world healthcare.
Yeah.
We're talking about that blend of, immediate action, but also that long-term watchfulness, that vigilance.
Okay, so let's dive right into that first crucial area.
Yeah.
The immediate time right after surgery, a really critical period. The source material really emphasizes the nurse's role, the RN's responsibility for that post-op assessment. So when a patient rolls out of the OR, what are the absolute, top priorities, the first things you look for?
Right. The absolute core, it's always the ABCs. Airway, breathing, circulation, they're just paramount.
Right, yeah.
Because, any little deviation there can spiral so fast, but it's more than just knowing the letters, right? It's about spotting subtle changes, being hyper-vigilant for specific warning signs beyond just those basics.
That makes perfect sense. So let's dig into that a bit. What are some of those key abnormalities, especially related to, say, oxygenation, circulation, those ABCs, but more specifically, and maybe some of the complications that aren't quite so obvious?
Yeah, what's really interesting here is it's often a cluster of signs, maybe subtle ones, like we're always on high alert for a potential pulmonary embolism. So you might see maybe a sudden jump in breathing rate. The heart races, tachycardia we call it. Maybe the patient gets really anxious, sweaty, diaphoresis, and then their blood pressure drops. That whole picture is a huge red flag.
Wow, yeah.
But you're right, it's not just the dramatic stuff. We're also watching for things like wound dehiscence, the wound opening up, or even worse, evisceration, where, organs might actually protrude.
Oh, wow.
And then the more common things too, like urinary retention, that can happen after anesthesia. Or atelectasis, where part of the lung collapses a bit.
And what about tracking things like fluid balance or the wound itself? What signals trouble there?
Well, for fluid balance, consistency is key. You're looking for signs that maybe they're not putting out enough urinary retention, or maybe they're dehydrated. A critical number to kind of keep in mind is normal voiding is about 30 milliliters per hour. Anything less than that that's abnormal needs attention.
30 mils.
Okay. Yeah. And with wounds, look, some initial bleeding, maybe some pinkish or clear drainage, that's expected. Serosanguinous or seroto, that's part of healing.
Right.
But the instant you see purulent drainage pus, or if the amount of any drainage starts really increasing, that's a definite red flag. Gotta let the physician know right away.
Okay.
And of course, vital signs. Any vital sign that suddenly jumps way outside the patient's normal baseline, like say a heart rate going from 80 up to 120, that needs immediate investigation.
So, okay, you've got maybe multiple things going on. How do you decide what to tackle first?
Yeah.
It feels like everything could be urgent.
Yeah, and that raises a really important question. Prioritization. It's critical. You always prioritize the issue that's the most abnormal and the one that could impact patient safety and health the quickest.
Right.
It connects back to those broader principles, Maslow's hierarchy, the ABCs again. Basic physiological needs, breathing, circulation always come first.
Makes sense.
And generally, an actual problem takes precedence over a potential problem. Acute issues usually trump chronic ones. And you try to go for the least invasive option first whenever possible. Safety is just. It's always the guiding principle.
And it's not just about reacting, right? It's also about preventing problems before they even start. What are some key things there?
Exactly. Prevention is huge. It's about constantly assessing for risks. Things like infection, falls, other injuries. And don't forget, bowel and bladder function things can really slow down after anesthesia. But honestly, a really crucial intervention, one that's maybe underestimated sometimes, is early mobility. Helping patients get up and move safely as soon as possible.
Really? Just getting them moving?
Absolutely. Even small movements can make a massive difference in preventing serious stuff like DVTs, those dangerous blood clots or atelectasis, the lung issue, and even helps get the gut moving again. Sounds simple, but it's incredibly effective.
Okay, speaking of preventing complications, let's switch gears slightly to infection. Always a major threat in healthcare settings. The materials highlight that pretty much all lines, foreign devices going into the body, are high risk.
Yeah.
Why is that? fundamentally?
Well, what's fascinating here and kind of scary is this concept called biofilm.
Biofilm.
Yeah. Basically, any device, an IV line, a catheter, anything inserted once it's in the body, bacteria can start to form this like slimy protective layer on its surface,
Right.
a biofilm. And this layer acts like a shield for the bacteria, making them much harder to kill and significantly upping the infection risk. That's why the care of these devices, meticulous care, is just absolutely paramount. It's not just protocol, it's about fighting that biofilm potential.
So when we talk about preventing infection with procedures, there are different levels of cleanliness, right? Like clean versus sterile. What's the difference and when do you use each?
Yeah, they're quite distinct. We use aseptic or clean technique for things like, say, putting in a peripheral, just a regular 4V in the arm or giving an injection.
Okay.
That involves clean hands, wearing gloves, and being careful not to touch the part of the needle or catheter that actually goes into the patient. It's about minimizing germ introduction. Sterile technique, though, that's a whole different ballgame. It's a much higher standard. You need that when you're entering parts of the body that are normally sterile, completely germ-free. Think central line insertions, changing central line dressings, putting in a Foley catheter, or even deep suctioning of the trachea. Everything, gloves, drapes, instruments, the whole field has to be sterile.
Right, much more involved. So given that risk with devices, what's the most maybe impactful strategy for managing the ones already in place? Is it just cleaning or something else?
Well, cleaning and maintenance are vital, but a really key principle, a point of critical thinking, is constantly asking, is this device still necessary?
Okay.
If any tube, drain, line NG tube, Foley, JP drain, chest tube, IV, PICC, central air, whatever it is, if it's no longer needed for the patient's care or it's just sitting there not being used, the safest thing is to get it out as soon as possible.
Just remove it.
Yeah. That is single-handedly the most effective way to slash the infection risk associated with that device. For the ones that do need to stay in, well, specific hospital protocols vary, but general standards involve regular dressing changes for things like central lines, usually at least weekly, and if they get soiled. Regular tubing changes for things like TPN to prevent bacterial growth.
Right.
And always make sure the device is secured properly so it doesn't move around, get dislodged, damage tissue, or create little entry points for bacteria. Securing it is critical.
Okay, from preventing infection, let's pivot to protecting the body's largest organ, the skin. Pressure injuries, pressure ulcers, they're a huge concern, especially for patients who can't move much. What's the deep dive here on prevention and healing?
Yeah, huge issue. And prevention is definitely the name of the game. It starts with figuring out why the skin might break down. Is it sustained pressure? Is it friction from rubbing? Too much moisture? And you also have to look at factors that might slow down healing if an injury does happen. Things like diabetes, poor circulation, or just overall poor nutrition or immobility itself.
So what are the key things nurses or even caregivers can do? It sounds like it requires constant attention.
It absolutely does. Vigilance is key. Some crucial nursing interventions include, first off, encouraging good nutrition, protein, vitamins, zinc. They're all essential building blocks for wound healing.
Nutrition, okay.
And then, yes, those pressure relief strategies are vital. Using pillows cleverly to cushion bony spots, like between the knees or under the heels, turning patients in bed regularly, usually every 2 hours if they can't move themselves.
Every 2 hours.
Yep. And if they're sitting up in a chair and immobile, repositioning them even more often, ideally every hour, maybe even more frequently depending on the risk. And for dressing changes, if there is a wound, often we use things like clean, wet to dry dressings. The goal is to keep the wound bed itself moist, which helps healing, but keep the surrounding skin dry to prevent further breakdown. It's a bit of a balancing act. Sterile technique isn't usually needed for chronic pressure injuries, more clean technique.
And when a wound does happen, the body has this amazing way of fixing itself, right? What are the main stages involved?
Oh, it's truly fascinating. The body's healing process generally happens in 3 main stages. First, there's inflammation.
Okay.
That's the body's immediate reaction. Blood clots form to stop bleeding. Immune cells rush in to fight off any invaders and clean up debris. It gets red, swollen, warm. That's inflammation at work.
Right, the initial response.
Exactly. Then comes the proliferation stage. This is where the rebuilding really gets going. New tiny blood vessels grow into the area angiogenesis. Healthy new tissue, called granulation tissue, starts to fill the wound from the bottom up, and skin cells start migrating across the surface to close it over.
Oh, you rebuild.
Yep. And finally, there's the maturation stage or remodeling. This can take a long time, weeks, months, even years. The new tissue gets stronger, scar tissue forms, and the wound gradually contracts, pulling the edges together. It's the body refining the repair job. Pretty incredible process.
It really is. Okay, let's shift gears again, this time to the heart. Our bodies pump. The sources emphasize really knowing what a normal heart rhythm looks like as a baseline. So what are the key features of what's called normal sinus rhythm?
Yeah, knowing normal is crucial before you can spot abnormal, right? So normal sinus rhythm, think of it as the heart's ideal steady beat. Key things are rate is between 60 and 100 beats per minute, not too fast, not too slow.
60 to 100.
The rhythm needs to be regular, like a metronome, just steady tick-tock. Electrically, you need to see one specific little bump, the P wave, before every main spike, the QRS complex. That shows the impulse starts in the right place.
P wave before QRS.
Yeah. And the timing between those waves, the PR interval and the QRS duration, they need to fall within very specific, narrow time frames. Basically, less than 0.2 seconds for the PR and less than 0.10 seconds for the QRS. It tells you the electricity is flowing smoothly and quickly through the heart's pathways. It's all about that regular, predictable pattern.
Okay, so that's the ideal. Now, here's where it gets really interesting and sometimes scary. When that rhythm goes off track, dysrhythmias, what kinds of things cause them? And more importantly, how do you respond in those critical moments?
Right. Well, causes can be really varied. Sometimes it's an underlying disease, like significant blood loss might cause the heart to race sinus tachycardia, or heart failure can cause various rhythm issues.
Makes sense.
But it's not always something severe. Think about everyday things. Too much caffeine, feeling really anxious, even strenuous exercise can trigger palpitations or irregular beats in some people. But the absolute critical takeaway for assessment, for recognizing what to do, is this. Always assess the patient first. Before you jump to conclusions based on a monitor, before you even think about shocking someone, you have to physically check them. Especially check for a pulse.
Check for a pulse. That seems vital.
It's absolutely fundamental because whether or not there's a pulse completely changes what you do next. It's the branch point for many decisions.
Okay. What about managing a really common one like atrial fibrillation, AFib? Lots of people live with that.
Yeah, AFib is very common. Management usually focuses on two main goals. One, preventing blood clots because AFib greatly increases stroke risk. And two, controlling the heart rate, because a rapid, irregular rate can make people feel awful and strain the heart.
Right, clots and rate.
Exactly. So we often use anticoagulants, blood thinners for clot prevention, and then medications like beta blockers or calcium channel blockers, sometimes digoxin, to slow that heart rate down. For some people, especially if they're symptomatic, a procedure called electrical cardioversion might be used to try and shock the heart back into a normal rhythm. There's actually a helpful mnemonic, sometimes used for AFib management, ABCDE.
Oh, okay.
Yeah. A for anticoagulants, B for beta blockers, C for calcium channel blockers, D for digoxin, and E for electrical cardioversion. Kind of sums up the main approaches.
A, B, C, D, E. Got it. That helps. Now, this brings us to something really crucial that often confuses people, myself included sometimes. Defibrillation versus electrical cardioversion. They both involve electricity, but they're used very differently, aren't they?
Oh, absolutely. This is such an important distinction. They both use electrical shocks, but they are fundamentally different life-saving interventions with different purposes and timing.
Okay, break it down for us. Defibrillation first.
Right. Defibrillation. Think emergency. Code blue. Its purpose is to stop life-threatening arrhythmias where the heart has essentially stopped pumping effectively. There's no effective cardiac output, meaning the patient has no pulse.
No pulse. Key point.
The key point, we use it for two main rhythms, ventricular fibrillation, VF, where the heart muscle is just quivering chaotically, and pulseless ventricular tachycardia, VT, where it's beating way too fast but producing no blood flow.
Okay.
The shock is high energy, and critically, it's unsynchronized. It delivers the shock at any random point in the cardiac cycle because there is no organized cycle to sync with. The goal is to basically stun the heart completely, hoping its natural pacemaker will kick back in with a normal rhythm. It's immediate. You see VF or pulseless VT, you charge, you shock, no waiting.
Okay. High energy, unsynchronized, no pulse, emergency. Got it. Now, electrical cardioversion.
Right. Cardioversion is different. Its purpose is to restore a normal sinus rhythm in patients who usually do have a pulse. They might be hemodynamically stable, but they have a symptomatic arrhythmia that's causing problems.
Symptomatic with a pulse.
Exactly. We use it for things like atrial fibrillation, atrial flutter, supraventricular tachycardia, SVT, or sometimes ventricular tachycardia if the patient still has a pulse.
Okay.
The energy level is usually lower than defibrillation. And the most critical difference, the shock is synchronized. The machine looks for the R wave, that big spike on the EKG, and delivers the shock precisely on the R wave.
Why synchronized?
That's vital, because shocking during a different part of the cycle, specifically the T wave, could actually trigger a worse rhythm, like VF. So synchronization is a key safety feature. And because the patient usually has a pulse and is conscious, cardioversion is often planned, maybe elective or urgent, and the patient is typically sedated beforehand so they don't feel the shock.
Oh, okay. So sedation is common for cardioversion.
Often, yes, unless they're unstable and it needs to be done emergently, even with a pulse, but typically sedation is involved because it's uncomfortable.
So summarizing the key differences. Defib is unsynchronized, emergency no pulse, VF pulseless VT, high energy. Cardioversion is synchronized, often planned or urgent, usually with a pulse. For AFib flutters, SVT-VT with pulse, lower energy, often needs sedation.
You nailed it. That's the core distinction, and understanding it is absolutely critical in cardiac care.
Fantastic clarification. Okay, let's widen our lens again to some systemic health issues, starting with the endocrine system. Our sources highlight two really interesting, almost mirror image conditions: Cushing's and Addison's disease.
Yeah, they're fascinating because they both involve the adrenal glands and the hormone cortisol, but in completely opposite ways.
Right, so Cushing's.
Cushing's syndrome is where the body produces too much cortisol. Think cushy, like too much padding. Cortisol is a stress hormone, so it's like the body is stuck in high stress mode. The mnemonic often used is stressed.
Okay, stressed.
Yep. Skin fragile, truncal obesity, that classic buffalo hump on the back and round moon face. Reproductive issues, elevated blood pressure, striae, those stretch marks, especially on the abdomen, sugar high, hyperglycemia, excessive body hair, and decreased potassium. It's often caused by tumors or taking high doses of corticosteroid medications for a long time.
Okay, stressed for too much cortisol, and Addison's is the opposite.
Exactly. Addison's disease is where the adrenal glands don't produce enough cortisol and often not enough aldosterone either, which regulates salt in water. So think low levels. The mnemonic here is steroids, kind of ironic.
Steroids for low steroids, okay.
Yeah. Salt hunger or craving due to low sodium, tiredness and weakness, often profound, elevated potassium, hyperkalemia, reproductive issues again, onset of low blood pressure, hypotension, increased skin pigmentation like a bronze tan, depression, and sugar low, hypoglycemia. This is often caused by autoimmune damage where the body attacks its own adrenal glands.
Wow, those mnemonics really help picture the differences. Okay, from hormones to breathing. COPD and pneumonia come up both very common respiratory problems.
Yeah.
What's the core issue with COPD?
Right. COPD, chronic obstructive pulmonary disease, it's basically long-term damage to the lung tissue, specifically the triny air sacs, the alveoli where oxygen exchange happens. The biggest cause by far is cigarette smoking.
Smoking, yeah.
But secondhand smoke, long-term exposure to workplace chemicals or dust, even some genetic conditions like alpha-1 antitrypsin deficiency can cause it. Key symptoms are shortness of breath, especially with activity, a chronic cough that often produces mucus, wheezing, sometimes weight loss, and that characteristic barrel chest appearance over time.
And how is it managed?
Well, the first step is always reducing risk factors, mainly stopping smoking. Then medications like bronchodilators to open airways, sometimes inhaled steroids. Oxygen therapy is common in later stages. Pulmonary rehab helps improve exercise tolerance. And vaccinations like flu and pneumonia shots are really important to prevent exacerbations.
You mentioned an interesting point about oxygen earlier.
Ah, yes. This is a key clinical insight. For a patient with confirmed COPD who starts declining, maybe getting more short of breath, you might actually increase their oxygen, even if their O2 saturation reading looks okay, say 95%.
Really? Even if it's technically normal?
Yes. In that specific scenario known COPD, clear decline increasing the oxygen can sometimes prevent a faster or deeper decline. It's a bit counterintuitive based just on the numbers, but clinically important. Now, if the cause of decline isn't confirmed, assessment comes first. always. And just for context, remember, room air, what we're breathing now, is only about 21% oxygen. Most of it is nitrogen.
21%. Good reminder. And quickly, pneumonia, there are different types we should know.
Yeah, mainly categorized by where you get it. Community-acquired pneumonia, CAP, you pick it up out in the community. Hospital-acquired pneumonia, HAP, develops 48 hours or more after being admitted to the hospital. And ventilator-associated pneumonia, VAP, a type of HAP specifically linked to being on a mechanical ventilator for more than 2 days. Different bugs, different treatments often.
Okay, so tying some of this together, the sources also touched on some basic but vital math conversions. Seems small, but sounds critical for safety.
Oh, absolutely critical. Precision is everything in healthcare dosing and measurement. Getting these basics wrong can have serious consequences. Things like knowing 1 liter of fluid weighs 1 kilogram, essential for tracking fluid balance, especially in heart failure or kidney patients.
Okay, 1 L equals 1 kilogram.
Yep. And 1 ounce is roughly 30 milliliters, ml. Super important for tracking intake and output. 1 tablespoon is about 15 millimil, or 3 teaspoons. 1 teaspoon is 5 milliliter. Knowing 1 kilogram is 2.2 pounds for weight-based dosing.
Right, those med calculations.
Exactly. And temperature 37 degrees Celsius is normal body temp, 98.6 Fahrenheit. 38 Celsius is 100.4 Fahrenheit, which is generally considered the threshold for fever. These conversions underpin so many skills, reading med labels, calculating IV drip rates, figuring out doses based on weight. They seem simple, but they are fundamental to safe practice.
Absolutely. And finally, there is a neat example of identifying a specific pattern in diabetes management, like a little bit of medical detective work.
Ah, you mean the rebound hyperglycemia or the Simoji effect?
That's the one.
Yeah, it's a really interesting one. It happens when a patient's blood sugar drops too low overnight, often while they're sleeping and haven't eaten for hours. The body then reacts by releasing counter-regulatory hormones, which causes the blood sugar to swing way high by the morning.
So it drops low, then shoots high.
Exactly. And the aha moment, the insightful intervention, is often surprisingly simple. Instead of just increasing morning insulin to treat the high sugar, you suggest a bedtime snack. Something with protein and carbs, like peanut butter on crackers.
A snack. How does that help?
That little bit of food helps stabilize the blood sugar through the night, preventing that initial deep drop. No drop, no rebound surge. It's a great example of looking beyond the immediate number, understanding the pattern, and finding a practical, often non-pharmacological solution.
That's brilliant. A bedtime snack fixes the morning high. Love it. Wow, what a deep dive this has been. We've covered so much ground from those first critical moments after surgery, through the careful world of infection control and wound care, into the heart's rhythms, clarifying defibrillation versus cardioversion, touching on endocrine and respiratory conditions.
And even basic math.
And basic math. All reinforcing how vital sharp assessment, precise calculations, and just keen observation really are. Every little detail matters.
It really does. And if you connect all these dots, you see healthcare as this incredibly dynamic field where knowledge has to be spot on, and decisions need to be quick but really well informed. Every sign, every number, every intervention, it all weaves together for the patient's well-being, often in ways you don't even consciously track moment to moment.
It truly highlights the incredible focus and dedication required from everyone involved in patient care. Which kind of leads to a final thought, maybe a question for you, our listener, to ponder. Thinking about these fundamental pieces of adult health, how might this understanding empower you? Maybe to engage more actively with your own health journey, or perhaps just to have a deeper appreciation for the quiet heroism happening in healthcare settings every single day.
Yeah, well said. We really hope this deep dive has given you a clear, insightful shortcut into this fascinating and absolutely critical world of adult health.